I'll set the stage here, and then I'll be turning over to Dr. Friedenson, Dave Friedenson. Some of you may know him. If you don't know him, he is the CMO of Reventics, and is a partner with us for all of our coding. Reventics does, as I'm sure you know, does all of our coding in emergency medicine. So he has been a great resource for us as we have been looking towards 2023, just a mere couple of weeks away, and some pretty significant changes that are coming down the line from CMS regarding how we do our documentation and how that documentation is coded. And just to set the stage a little bit, these changes are the only changes that have been made since the 90s. The last time there was a significant change to what emergency medicine documentation looked like and how it was coded occurred in the 1990s. So we've had this paradigm for all this time of what it looks like to do a good ED chart. That is going to be shifting significantly. It's going to be a seismic shift that occurs as of January 1st. And of course, to ensure that we are not only improving our documentation from a quality and medical legal perspective, but ensuring that we are capturing the revenue which is appropriate for the good work that you are all doing, and to ensure that you personally are capturing the RVUs for the work that you're doing to be reflected in your bonus compensation. We want to make sure that you have the tools available to you to make sure that that documentation is in alignment with what are the new CMS rules around this. So I just sent out, just prior to this meeting, a quick reference and tips document that if you have it handy, might not be a bad idea to sort of pull it up and refer to it at times during this presentation. I think you'll find that what Dave Friedenson has to present here today is going to reinforce many of the points that are contained there. So without any further ado, and in the interest of time, I will hand it over to Dave. And before I do, just a quick shout out to the folks from our team who have been really integral in getting this ready, to go over the finish line. Julie Marshall, Andrew Sheridan, Kelly Schutz, Greg Marchand have been really, really very instrumental in getting us to this point and setting us up for success as of January 1st. So thanks to all of them, and thanks to Dave for his partnership with this. And with that, I'll turn it over to him.
Thanks for the introduction, Dave. And yes, thank you to your team for the collaborative work. And thank you for all the emergency physicians and providers who are taking care of the patients. So our goal is to get you to, document well without having to document too much more than what you're used to. And that way we can get credit for the work that we're doing. I always start with the compliance slide. And one of the things about the new rules is that there are certainly opportunities to over document and therefore commit fraud. And we don't want to do that. We want to document correctly to capture the level of illness, the seriousness of the patient's presentation. And then we can code that correctly. So don't construe anything that I'm saying here as you should over document to get more credit. You should document what you're thinking to get the correct credit. So, why does documentation matter? Remember, today we're talking about what you need to document for coding, but there's also documentation to protect you medical legally. There's documentations that really everybody else knows what happened with the patient when they see them the next day, or when the hospitalist takes care of the patient upstairs. So you do need to document well for those reasons. And then there's also the coding piece. So what's the big change? So the seismic shift is that starting in January, you may document your appropriate history and physical exam. But we won't have to downcode you if you forget one physical exam item, or you forget one review of systems item, or you forget your family history on the OBS patient. We actually can code the chart with the medically appropriate history and physical, because we will code your chart based on the levels as set by the medical decision making instead of the history and physical and the medical decision making. So that's sort of the key. And the history and the physical are still important because they tell the story, they talk about the abnormalities, but you don't have to worry about missing one element of something. And, sometimes we do pick up something on a review of systems that we had no idea about, like that necrotic toe, or, something else that sort of triggers us that this is more serious. But we don't have to downcode you because of an incomplete history or physical anymore. So that's great. So what is the medical decision making? So there's going to be 4 levels of medical decision making, and those 4 levels translate into essentially 3 categories. And so you need 2 out of 3 categories to get to the level. And it's the presenting problems is one category. The next category is the amount of data. And then the final category is the risk of what you're doing or not doing for the patient. And then one of the key things that really helps us as emergency physicians is that CPT and the AMA emphasized the presenting problem is what drives the level of the patient. It's not what your final diagnosis is. So, when United Healthcare downcodes us because the chest pain turned out to be reflux, that goes against the rules as emphasized in the new rules. If you have a presenting problem that's serious, and you do the appropriate evaluation of that presenting problem, it's just as serious if you find an MI or you find something minor. So a brief description of what are the problems. So from a problem standpoint, we have low, moderate, and high. And the low problems are really those minor uncomplicated illnesses or injuries, things that you could see in triage and dispo, or you see them and you send them out the door. The moderate ones are people who have minor exacerbations of problems, a simple systemic illness like the flu. And then the high problems are the things that are severe, intractable, out of control pain, or potentially life or disability threatening injuries or illnesses. And then things that are threatening to organ systems. So those things that could be critical care if you find something serious, or not critical care if you're looking for it, but it turns out to be okay. And then the risk category. So we have one category is problems, another category is risk. So under risk, things that get you to those levels of risk. Low risk, which is the difference between a level 2 and a level 3, comes down to if you document your over-the-counter medications, that would be the difference between a level 2 and a level 3. Other things that you do for the patient that aren't really high risk are low risk. So recommending physical therapy, needing to get social work involved in a case. And then moderate is prescription drug management or social determinants of health, or if you have a patient like who blew out their knee and they're going to need elective surgery at some point in the future. Those would all be moderate risk things. And then the high risk things are things like needing emergency surgery, or you consider emergency surgery, potentially needing an admission, or escalation or de-escalation of care, so that making a patient DNR. And then also high-risk medications, including parenterally controlled substances. So, the dose of IV Dilaudid or fentanyl would make something high risk. And so what we're going to talk about is how do you document these things so you get credit for those things that you just did.
Hey, Dave, if I can interject 1 second, I meant to say if anyone has any questions as we go, please feel free to document those questions in the chat and we can respond to them in due time. Thank you.
Thank you. So one of the ways that we can do a good job of documenting how serious we thought the presenting problem was and what the risk is of that presenting problem is if we do an initial assessment. So you do your history and physical, and then you document an initial assessment, which is your initial impression of what might be going on with the patient, not what's definitely going on with the patient, and then what I'm going to do about it. And that way you get credit for the more serious thing that you're going to rule out and turns out not to be serious. So this is an example, and you wouldn't use this example in a minor injury, but if you have somebody who, this patient presented with a pretty significant ankle injury, there was bruising, swelling, they were unable to bear weight, it was concerning to you that it might be a fracture and might require emergency surgery or urgent surgical repair. So we did some x-rays to further evaluate for a potentially serious or disabling injury. So after the imaging was back, it's clear the patient will benefit from splinting, but doesn't need admission or surgery. What this does is it captures your level of concern for the patient initially, and then it also captures you weren't in the end, you did the right workup and treatment, and then the patient is stable for discharge. And so one of the things to point out here is that, we talked about high risk is emergency surgery. So the fact that you consider emergency surgery is high risk, even if it turns out they don't need it after you do the appropriate evaluation and management. So the patient who you see walk in or run in or jump into the room with their ankle injury, you're not going to document it like this, right? But when you have that bad ankle injury, that's when you document your concerns to that level.
Hey, Dave, one quick question for you. I think I know the answer, but I'll defer to you. One of our docs asks, is observation the same as admission? In other words, if you're documenting the consideration of admission or observation, or if you end up admitting or observing the patient, are those considered equally, admit versus obs?
Yeah, that's a great question. So observation and admission would count the same. So technically, any escalation of care would count the same as admission. So so observation and admission are the same, but if you have, for instance, a psych patient who came from home and now you're considering putting them in a halfway house or a group home, that would be escalation of care, and that would count the same as observation or admission. And likewise, a day admission for a psych patient would also count to that same level. Sending a patient who came from home to a nursing home or a rehab would also be admission. So anything that's an escalation of the level of care that they came from counts as a consideration of admission. So good question.
One more, Dave, and then we'll move on.
Sure.
Do we have to spell out might require emergency surgery? In other words, do we say this patient has these symptoms and I'm concerned they might need surgery, or is simply stating the concern for a diagnosis to say I'm concerned this patient may have appendicitis or a hot gallbladder, for example? Is that sufficient? Do you need to be explicit in saying the words might need emergency surgery?
Yeah, and that's a great nuanced question, because what it comes down to is if it's obvious that this diagnosis you're considering could only be treated with surgery, then you don't have to explicitly say it. So a good example of that would be the patient who falls, bumps their head, and intracranial hemorrhage is in my differential diagnosis. Well, an intracranial hemorrhage is only treatable with an admission or a surgery, right? We never send an intracranial hemorrhage directly home. We might observe a tiny subarachnoid hemorrhage for 6 hours, repeat a CT scan, and then send them home. But they're never going right home. So in that case, it's obvious that they need surgery, and so it's implied, and we can count that. But in the case where it's not obvious and implied, or it could have a couple of different branch points, then you would have to explicitly say I was considering surgery in this patient. And I think a good example of that would be a diverticulitis patient. Might need just antibiotics, might need surgery, might need admission and antibiotics. So there's lots of branch points. So that couldn't tell us that you were obviously considering surgery or admission when you further evaluate that. So moving on to data. So there are 3 categories of data. And the reason why it's important to know that there are 3 categories is because for a low or a level 3, you just need either an independent historian or 2 data points. So your urine and urine pregnancy test gets you to low data, which would be your level 3. For moderate, you need 3 data points, or you can interpret something yourself, or you can discuss the management with another appropriate person or the interpretation of a study with another person. And then for high, you need 2 out of the 3 categories. So those 3 categories are the points, the discussions, or the interpretations. And so for a level 5, you would need either points and discussion, points and interpretation, or discussion and interpretation. And so documenting those things is how you get the credit. So if we don't know you had a discussion, we can't count it. If we don't know you interpreted something, we can't count it. And this interpretation is one of the big changes. It used to be that you just had to independently view your images. Now it's an interpretation. And we'll get into the details on what is an interpretation. So for tests, those data points, the data points, you get a point for every individual test. So a CBC, a Chem 7, and a troponin is 3 points. And that's different from this year where it's 3 lab tests was actually only 1 point, because they would only give you a point for labs, a point for imaging, and a point for the other stuff. So now you get a point for each individual test you did. So a trauma patient will give you 4 points because you do a CT head, neck, chest, abdomen, pelvis. That's 4 points. And then if you interpret it, you get that other category, and now you have high data. We can't count points on things that we're billing separately for. So if we're billing for an EKG, we can't count the points. If we're billing for a fast exam, we can't count the data points. You still get to bill for the exam, but you can't bill for the points. And we'll talk about ways you can get credit under risk if we're not able to bill for those points. And then outside records, this is a new change. It used to be any old record, and now it's outside records. And outside records are any different specialty or a different facility. So, if you are reviewing your partner's emergency note from yesterday, that doesn't count as an outside record. But if you review the hospitalist note from their last admission, that counts. And so what matters for documentation is documenting whose outside record you reviewed. And then, if you got anything pertinent, obviously it makes sense to document what you got from a pertinent findings. Patient reviewed the cardiology note from last time, had a cath in 2012. And then independent historians is really anybody. This really is important in the pediatric population or the elderly population where you're getting history from somebody else. That gives you a data point. And it's important to document who that independent historian was.
Hey, Dave, one quick question that's a good one is related to discussions that we might have internally amongst our colleagues within the department. So if I'm a PA taking care of a patient, I've discussed the case with an attending physician or just get a curbside from a colleague working alongside of me. I would assume that those do not count towards this because they're not sort of outside of the realm of the ED, but could you speak to that, please?
Sure. Yeah, and that's accurate, unfortunately. So discussions within the department don't count. So a physician talking to a PA or the physician talking to the nurse does not count as extra points. Talking to an outside provider is what counts. So talking to the SNF nurse to get a history would count, but talking to the emergency department nurse would not. And talking to your other colleagues in the department would not count. Social work is considered an outside provider. So even if they happen to be stationed in the ED, it's a different type of provider than the person working in the ED. So you could count the social worker who is there. Likewise, the pharmacist would count. The CT tech would count. So all of those other folks besides your own nurses, your own techs, your own secretary, and your own physicians and PAs. The next category, independent interpretation. So what does that mean? So to interpret something, they're not looking for a radiologist's interpretation and report. What they're looking for is, did you look at the images and did you make an independent decision about what they said? And so if you look at the chest x-ray and you see an infiltrate and you document, chest x-ray per my interpretation showed an infiltrate, or chest x-ray on the trauma patient did not show a pneumothorax. Those things that emergency physicians do all the time to make sure that we're taking good care of our patients, that's what your interpretation is. Likewise, if you look at the CT scan to see, can I see the stone at the UVJ? Is there hydronephrosis, et cetera, those pieces that you're looking at. And then I did want to point out one of the things that we do with relative frequency is a bladder scan. We ask the nurse to do a bladder scan and they say, hey, that showed 40 cc's. Your interpretation that that's not a post-void residual or a significant post-void residual is an interpretation of a study. And so document that as an interpretation. And then discussion of management. So whenever you say I consulted somebody, that actually is not good enough to get the points for a discussion. There has to be, something that says I talked to somebody, I spoke to somebody, I discussed the case with somebody. And then obviously from a quality standpoint, you want to say what you discussed. But it's a discussion of management with anybody who is acting as a healthcare provider. So that could be another physician. It could be when you call the CT tech, or the CT tech calls you and says, hey, the creatinine's 1.6. Are you sure you want me to use IV contrast? That's a discussion of management. Or the law enforcement officer who's taking your patient to jail, and you say, you know, make sure the nurse checks in on them every 4 hours in case they have a head injury. So all of those are discussions of management with somebody. So you document who you discussed the case with and what you know, that there was some management of what that was. And then the other one would be the interpretation. So if you talk to the radiologist calls you and says, hey, the CT showed no bleed or no AAA. That counts as a discussion. Go ahead, Dave.
Yeah, sorry, just a couple of questions. You sort of answered one, but the question is, if you're looking at a radiology study and providing an interpretation, does that count even if the radiologist is providing their own independent interpretation? The answer is yes. Another reason that we should be looking at all of these studies and documenting our interpretation of all of the studies that you're ordering for your patients. And then the second was regarding consultations, like if someone's calling the cardiologist, for example, is it sufficient to say, I spoke with the cardiologist about this patient, or do they need to say, I spoke with the cardiologist and we specifically discussed X, Y, and Z, and they asked me to do A, B, and C?
Sure. And this is where I think there's a branch between what we need for coding and what you need for quality. So there may be key parts of your conversation that are important for quality of the chart. But from a coding standpoint, we just need to know that you discussed the case with somebody. It's assumed if you're discussing it, actually, I should say, if you discuss it with somebody, that it was a management discussion. So it was, you know, and not a history discussion, because that is different. Discussion of management is a whole category, whereas an independent historian, if you call the patient's cardiologist and say, and ask them for history on the patient, that's actually just going to be an independent historian. But if you're calling the cardiologist as a consultation, then obviously it's a discussion of management. And so you don't need to document more for coding. But you might want to say, cardiologist said, yeah, just start him on aspirin. I'll see him in the office in 3 days. What you document really comes down to the quality of your documentation. And then other outside records that I just thought of to mention is, you know, prescription drug management programs still count as outside records, and a regional health exchange also counts as outside records. So it doesn't have to be a hospital, facility, or doctor. One of the nice things about the new rules is you get credit for things that you thought about but didn't do, or you wanted to do but didn't get done for a good reason. The only way we know that that happened is if you document it, though. It's easy for us to see you ordered a CT scan and give you a CT point, but it's hard for us to know you thought about ordering a CT and ultimately didn't unless you document that. So if you think about doing a test and the patient refuses it, then document that you were going to do that test, but the patient refused it. You now get a data point for that test. Likewise, if the patient demands a test and you convince them with shared decision-making to not do it because it's not necessary, if you document that, you get a point for that test. And then likewise, if you're considering emergency surgery or hospitalization, but the patient refuses, or the patient gets better and goes home, then those are all things that if you document them, you get credit for that level of service, even though it ultimately didn't happen. So it's important for you to document your thought process, both from a quality standpoint and from getting credit for coding.
Hey, Dave, one other question, which is a good one, is related to the role of residents. Obviously, they are sometimes having these conversations with consultants or independent historians. And the question, I guess, is there documentation of those conversations, or us noting that the resident had those conversations, is that sufficient for coding purposes? Will we capture that? Right.
So in theory, you're getting credit for every medical thing that happens with the patient that the resident does, as long as you're supervising them appropriately and you see and evaluate the patient. So when the resident talks to somebody else, you should get credit for that, because that's part of that that whole resident medical supervision. As we know procedures, you actually have to be in the room to supervise them. But for the medical part, you can supervise them and then sort of trust and verify what's going on. So residents, yes. However, it's explicitly stated in the rules, if your nurse talks to somebody or your tech talks to somebody, then you don't get credit for that. So a good example of that would be if you have the secretary call the poison center for you, you wouldn't get credit for that discussion with the poison center because it was a non-medical person making that call for you. Other things that you can get credit for when you do them or don't, and they make a difference in the level of service. So we talked about over-the-counter medications. This is sort of one of those key things that's the difference between a level 2 and a level 3 patient. And often you have a minor patient who would be a level 3, but you didn't do anything for them except evaluate them to make sure something serious wasn't going on. And in those cases, you're telling them to take Tylenol or Motrin for their fever or for their aches, but it doesn't make it into the record. So documenting the over-the-counter medication recommendation is really important. You don't have to call out a specific medication, but you should mention that you told them to take OTC meds for comfort. And then the severity of the presenting problem is really key. One of those things that we're missing sometimes. You know, we see somebody get some IV opiates. It must have been pretty severe if you're going to give them IV opiates, but nobody documents that the problem was severe. It's the patient presented with abdominal pain and I gave them fentanyl. So if you say the patient presented with abdominal pain that's severe enough to require fentanyl, or the patient presented with severe abdominal pain or intractable abdominal pain, those are things that trigger us to know that it was severe, and then we get credit for a high presenting problem.
Hey, Dave, regarding over-the-counter medications, if we're advising the patient to take them, does that need to be explicitly documented in the body of our provider note? Or if we include that as part of the discharge instructions, will that suffice? Do the coders look to the discharge instructions to capture these elements?
So the coders do look at the discharge instructions. So as long as they're in your notes somewhere, then we'll capture that. We get a summary of all of the orders and the instructions and the actual medical note. So the key is that it's in there. If the patient's provided with a written set of instructions that didn't come from the computer, we might not get that.
And this is probably a good time to interject here and say, please keep in mind that our coders are human, right? And they're reviewing a tremendous amount of information for every chart that they're reviewing. So the simpler you can make this on them, the more likely it is that these elements will be captured. We can say, yeah, they'll find in the discharge instructions, but nothing competes with having it front and center in your note and saying, hey, I told this patient they need to take X, Y, and Z for management of this, whatever. So be as explicit as you can. Pretend you are painting a picture with your note, and someone needs to look at that picture and have a full understanding of how that visit went from start to finish. That's really the bottom line.
Yeah, it's a good point. And, you know, it's a fine line between note bloat and having your note look good, but having a single source in your note of what happened with the patient really is beneficial, both from a coding standpoint and from a you know, I'm the emergency physician reviewing your note from yesterday to see what happens. You know, it's good to have it all in one source so we don't have to look up 16 different things. Prescription drug management. So what I wanted to point out is if you write a prescription, then we'll know about it. But if you don't write a prescription after thinking about it, we don't know that unless you document it. And so in those cases of otitis media, sinusitis, bronchitis, URI, where you're not doing a prescription, but you've talked to the patient about it, and there's a good reason why you're not, that counts as prescription drug management. So documenting that conversation gets you credit for the prescription drug management. And then the other thing is if you tell somebody to stop taking a medication, like they fell and hit their head, so you want them to stop taking their aspirin for 2 or 3 days, that might be something that if you talk about that, maybe not aspirin because it's not a prescription, but if you tell somebody to stop taking a prescription drug for a few days, that's prescription drug management. So anytime you start, stop, continue, change, or decide not to do a prescription, that counts if you document it. And then social determinants of health. So social determinants of health are moderate risk, which would be level 4 risk. And what's a social determinant? If there's something, a social factor that impacts your ability to either diagnose or treat somebody, that's a social determinant of health. Patient comes to the ED for their minor injury because they can't get into their primary care doctor because they have Medicaid and it'll be 8 weeks before they can get in. That would be a social determinant of health, which may be the difference between a level 3 and a level 4. Or the patient works 7 to 7 and their doctor's office is closed. That's a social determinant of health. Linking the social determinant of health to what the problem is that you're addressing today is how you get credit for the social determinants of health. So in summary, the key things to talk about are your initial assessment. Were you considering admission, higher level of care, emergent surgery, elective surgery? Does the patient have risk factors or comorbidities that puts them at higher risk? And documenting those things in your initial assessment really helps to get you there. And then in your final assessment, talking about things that are affecting your disposition of the patient, like their social determinants, like their prescription or lack of prescription drug management and their over-the-counter medications. And then also it's good quality to document why it's okay to send that high-risk patient home now that they're going home. And then with that, we will move on and talk about a few cases that demonstrate these levels of service.
Hey, Dave, can I make one additional quick note?
Sure.
For MEP specifically, you know, the social determinants of health, so many of our patients are impacted by social determinants of health, and we have not, as a group, historically done a very good job of documenting those. We're aware of them, we deal with them all the time, but we don't always document them. And in the interest of sort of reminding all of us of the importance of that, we are adding a section to the workflow in MedConnect that's going to be called Relevant Social Determinants of Health. And it will be a place explicitly there for you to go in and remind yourself that you can use that area to document what are the social determinants of health, recognizing that these are, again, factors that make it for a higher risk visit. They're so prevalent amongst so many of our patients. And there'll be a dot phrase, .ed social determinants, that will serve as a prompt. It basically says this patient has these social determinants of health which are impacting our ability to care for them during this visit, blank, and you fill in the blank, whatever those social determinants of health may be. So keep an eye out. That change is not yet live in MedConnect, but it will be prior to go live.
Great, thank you. So what I'm going to do is I'm going to go through a few cases that demonstrate the difference between different levels based on how you document and how the ideal way to document these things would be. So this first case is a level 4 versus 5, depending on how you document it. And again, remember, I don't want you to over document, but if you were thinking these things and you put them down, then it's, you know, a good idea to document it so that we can give you the right level of credit. So this was a 30-year-old female who arrived in the ER with nausea, vomiting, bloody diarrhea, has a history of GI problems. And then in the differential diagnosis, there's talk about inflammatory bowel disease and ulcerative colitis. And so this presents as there's nothing there that says this would be a life-threatening condition or a condition needing surgery. And if you weren't thinking about things that need surgery or potentially life-threatening or potentially admitting illnesses, then that's fine. But if you were thinking that in the back of your mind, gee, I'm going to get a CT to make sure they don't need surgery, then documenting that would be the difference in this case going from a level 4 to a level 5. Because our problem is an exacerbation of a chronic problem. The data, there's a discussion with their GI doc plus the labs and the CT, so we can get to high data. And then the risk is we're prescribing some medication. And so the risk is moderate, the problem is moderate, and then the data is high. So this could be a high or a level 5 if we either thought it was severe and the patient was tachycardic and dehydrated and had electrolyte disorders, so maybe we did think it was severe. Or if we thought the patient might need admission or surgery depending on CT findings, and that's why we did the CT. So either of those two things documented could have gotten this to a level 5 instead of a level 4. This next case is a well-documented chest pain patient, and I think addresses the question that somebody had before, which is, so the patient presents with chest pain and hypertension, which was a high problem. And then the data is moderate because they had more than 3 labs. And then the risk was high, even though they didn't say, I'm thinking of admitting the patient or sending them to the cath lab. In this case, it's implied. And why is it implied? because we're concerned about chest pain due to an MI, and we did an EKG and troponin. So we have a complaint that we're concerned about a potential life threat that is only treated with sending them directly to the cath lab or admitting them to the hospital. And then we did the appropriate workup for that problem to demonstrate that we were concerned about that. So that's why it meets the high risk, even though we didn't explicitly say I'm going to the cath lab or admission, depending on the results of the EKG and troponin, because there's really no other outcome for that patient. Now, if the patient presented with chest pain and you didn't say you were concerned about an MI, then that's different because now we don't have the life-threatening differential that can only be treated in the cath lab. Maybe you were looking for myocarditis or pericarditis. So talking about that life-threatening surgical process is how you get credit for it if you're not going to document that you were concerned about admission or surgery. This is a well-documented level 4 case. And so I wanted to point out that not every case is a level 5, and that's appropriate. So this is a patient, again, who presented with nausea, vomiting, dehydration. So the concerns were some things that are not really life threats, but what's actually concerning to you. And then there's a good description of we're not really sure what's causing it, but we're going to treat it, make you better, and you can follow up. And a undiagnosed problem with uncertain prognosis that I'm recommending a further workup is a moderate problem. So it defines it really as a level 4 instead of a level 3. And then we talk about our prescription drug management. The patient got fluids and Zofran. And then they were dehydrated, which is a complication of a problem. And so dehydration would then be, make it a level 4 instead of a level 3. So there's a lot of things sort of pointing towards a moderate problem, and then the prescription drug management gets you moderate risk, and this is just a solid level 4 case, well documented. This one is a good case of documentation of when we didn't do something, so I wanted to point that out. So this is an elderly patient who came in, and she was offered a full workup, including labs, urinalysis, and CT. So we didn't do them, but we were offered them. So there's 1, 2, 3 data points. So that's moderate data, even though we didn't do it. And then there's the evaluation of, here's what we were concerned about. We were concerned about a UTI, appendicitis, diverticulitis, and other acute abdominal pathology. But turns out it's just constipation. So one of the things that might be helpful in this patient, since we didn't do the CT, is if we initially considered the surgical process, but the patient improved, so we didn't end up doing the CT scan. Now we're talking about a level 5 in a patient that we didn't do the workup, versus the way we've documented it, we're sort of saying, you know what, I really wasn't thinking about those things, and the patient's better and going home without any testing. So that would be a level 4. So how you document it can, when it's not clear that there's a surgical process, really helps to solidify what you're thinking and the level of service. This one I wanted to point out as a good description of a potentially disabling condition. So disabling problems are level 5 problems, and also description of a problem that could only be treated with surgery or admission. And we do the workup that's appropriate for that. So sometimes we see a CT scan of the spine or an MRI of the spine ordered for back pain, or, it could be a disc. Well, those aren't necessarily surgical problems. They could be, or they might not be. Whereas cauda equina or cord compression really is a surgical problem, or at least admission to the hospital. So the fact that we document we were concerned about that gives us credit for that high presentation, the potentially disabling presentation, and the high-risk emergency surgery or admission. So when it's obvious, you'll get credit for that. And then this one, level 3 versus level 4, the antibiotics and sore throats. This is a borderline case, and I kind of wanted to point it out to Dave's point of, we're dealing with coders who are looking at a case and they're human, so they might interpret it one way or the other. And so if we make it clear to them, then we can make our level of service clear. So the differential diagnosis included some things that would be treated with antibiotics, included viral pharyngitis, And then we say the patient's not given any antibiotics because this is viral pharyngitis, given the strep is negative. So the question is, did you consider antibiotics until you got the strep back, or did you not? Were you all the time thinking this patient doesn't need antibiotics? And it is subtle, I would say. When I asked a bunch of compliance officers about this case, some of them said, yeah, I would have taken that as a prescription drug management. And others said, they didn't explicitly say, we discussed antibiotic treatment with the patient, but given the negative rapid strep, we're not going to prescribe antibiotics. So, I would say that the coders might code this as a level 4 or might code it as a level 3. And the ideal way to do it would be to say, I had a discussion with antibiotics with the patient, and they said, and we decided not to prescribe them, or we were going to prescribe antibiotics, but the strep came back negative. This is a high-level case, or potentially high-level case. So the patient came in with severe sore throat, severe pain, and it was severe enough that it was causing tachycardia, dehydration. So that's a high-level thing. And then we did a CT scan, so the question is it a level 5 or a level 4? Well, why are we doing the CT scan? So in our note, we talk about strep, we talk about peritonsillar abscess and COVID and influenza. And then we say we did a CT scan. She's got a hot potato voice, and then the CT was done to rule out a peritonsillar abscess. So some peritonsillar abscesses we know get surgery, and some of them get steroids and antibiotics and watched. So it's not a guarantee of emergency surgery. So we can't give you credit for that high risk the way this is documented. But you're probably doing the CT scan to see if they need surgery or a procedure, or if they need admission, or if they have airway compromise. And so if you document it that way, then you'll get credit for the high risk. And then also, if you interpreted the CT, you could get a high data, and that would also make this a level 5. And probably if we're doing a CT on a sore throat, we're looking for, a surgical process. And then complicated injury versus in a level 3 versus a level 4. So this is a finger injury. And because we're concerned about a fracture, it's a moderate presenting problem. As documented, this is a level 3 because we talk about being concerned about potential fracture, but it turns out not to be. And then we're sending the patient home. But if we interpreted our X-ray and said, X-ray interpretation per me showed no fracture, then we'd have moderate data and it would be a level 4. Over-the-counter medications were documented appropriately, which is good, and that way we get the low risk. And then this case, an elderly patient, 93-year-old, came in with weakness and then also spinal stenosis. We have in our differential diagnosis an MI or pneumonia, and then the patient was not hypoxic. And what I wanted to point out on this is that they got a PT evaluation to see if the patient is safe to go back to his level of care. So clearly we're thinking about maybe this patient isn't safe to go home, but we didn't document it. And so if we said, is he safe going back to his level of care versus being admitted to the hospital, then we can get credit for that high level patient. Now, in this case, they're actually, they talked about an MI and they did the EKG and troponin and chest x-ray, so they would get it anyway because they got credit for the MI. But I did want to point out sometimes, it is the evaluation, and then also the PT evaluation. Did you talk to the physical therapist versus just get a PT evaluation? Because if you had a discussion, then that gets you your high data. And I think we're coming up on the end, so maybe I'll stop here and see if there are questions, and that way we can honor your time.
Are there any from the chat that I missed? I think I got most of them. Oh, here's one that I think I didn't ask. It's from Corinne. If you're completing a triage clinician note and the patient elopes, what what is the role of documenting review of labs and CAT scan for that patient if those were done while awaiting getting into a room?
Yeah, so if things are ordered from out front, then it's important that the person who's doing the note has those in their note that they were ordered, because remember, you get points for either ordering or reviewing the tests. If they were never done, then just ordering them actually gives you the level of service. So those 3 labs that you ordered from triage would count towards moderate data. And then it's just a matter of documenting your problem or your risk. If they did get done, then obviously from a quality standpoint, you should review the results. And then you also, documenting anything concerning gets to the correct level of data as well.
One final question, Dave. Is there a list of high-risk diagnoses that could be sent to us, like would deep space neck infection count as opposed to a peritonsillar abscess? So I guess is there a specific list of diagnoses that the coders are referencing that would bump something to a higher level of complexity?
Yeah, great question. So I'm actually spending this month reviewing lots of cases, and as I review the cases, pulling out things that I think the coders should automatically count as high risk and things that they need better documentation for that. And once I'm done with that, which I anticipate being done with by the 29th of December, I can forward that to you all as well as a list of potential high risk diagnoses in addition to the talk I'm giving to the coders then.
And let's not forget that you also have the ability to characterize in your note that something is high risk, right? So you need not necessarily refer to some list and choose something from the list. Just document it. If in your estimation it is a high risk scenario, just document that, or that this is a risk of limb or life threatening illness for the patient, then just document that, and that also should suffice, because your clinical judgment and gestalt is quite valuable in making that determination.
Yeah, and that's absolutely true. And whenever we fight down codes at audits, if the physician noted that they were concerned about something life-threatening or high risk, then the auditor has no choice but to accept it. Whereas if the physician doesn't say that, then they argue it until it gets down coded.
All right, no other questions. If folks are willing to hang on the line, I can share the document that I created today. We can just go through it as a final cap to the discussion. That was really excellent. Dave, thanks very much. Appreciate your work on this. Give me just a moment. Let me see if I can share my document. Hopefully you can see that. So the first section here is just kind of introductory. Bottom line is basically, don't forget your exam and review of systems, but don't focus on the number of elements. That reinforces what Dave pointed out. And instead, what you really need to focus on is the complexity and medical decision making that you're doing to manage those issues. Some high yield tips. I stole this one, Dave. Hope you don't mind. If you think it, ink it. I like that very much. Just make sure that you are very explicit in your thought process from start to finish. Again, focusing on complexity and medical decision making. That's where the money is. The bulk of your medical decision making should be in this the assessment and plan section. So in other words, after the initial assessment, that's when you want to sort of document what you're thinking, why you're ordering the tests, what is the rationale for the care that you're providing. We are renaming, it was previously called assessment and plan. It's now going to be called assessment and plan / medical decision making, just to make it more clear that that's the appropriate place to document that. Document why you're ordering labs or imaging studies. So you're ordering these tests, or someone is ordering tests for this patient. Document why that was, why you ordered those. That counts. Document your review of the lab data, even if it's normal. If you go in and say, hey, I've reviewed all the laboratory studies of significance, the patient has a leukocytosis and is acidotic, that's really helpful to sort of paint the complexity, and that review of that data will help with your documentation. We talked about this, your review and interpretation of radiology images. Even if radiology is providing a report, it doesn't change the fact that you can independently review that and document your interpretation, and that counts. Document conversations literally with anyone involved in the case. You can see the list here, but literally anybody who's involved in the care of the patient. Review of prior records. External notes, CRISP would be included in that. If you're referring to CRISP and reviewing external documents from CRISP, that is certainly relevant, and you should document that. Social determinants of health, we talked about this. So many of our patients have this. We're going to add this new section to our workflow to allow you to capture these elements, and the new dot phrase ED social determinants will help prompt you to do that. Medication management, this can include high-risk meds that you're giving. They're listed here, but some vasoactives, RSI, procedural sedation, opioids, insulin drip, lytics, heparin, etc. But also reviewing their current meds that you are prescribing and why you're prescribing them, and even if you're advising the patient to take over-the-counter meds, documenting what you're advising them to take and why will help bolster that documentation. The more diagnoses, the better. This has always been true, but this is true now. It really helps illuminate for the coders the complexity of the case. If you have one diagnosis versus 7 diagnoses listed, it's obvious that 7 diagnoses demonstrates some added level of complexity for the case. And then the last one I called just put a bow on it. I think there were a couple of examples that Dave Friedenson showed that really, really great summary of what's going on with the patient. So at the end of your assessment, just include a statement as to what you're doing with the patient and why you're doing it. The patient's safe for discharge because X, Y, and Z. I was concerned that they might have some surgical process, but the CAT scan is negative. Their labs are fine. The patient's feeling better after some medications. We're going to send them home. Or if they require admission, because of X, Y, and Z, the patient has no primary care doctor, they have no transportation, it's unlikely they're going to be able to get their medications, and the patient has some hypoxia with community-acquired pneumonia, we're going to hospitalize this patient. So just describe it very explicitly what that looks like and why you're making those decisions, and that will be very helpful for the coders to really identify the complexity involved in your medical decision making and your rationale for doing these things.
That's great.
2 last questions. Is there a change in definition for critical care billing? I'll defer to you on that one, Dave, and then follow up to that is, and does critical care billing automatically get you to the level of 5?
So there is no change to critical care, except that unfortunately the time for critical care, it's longer for the second hour. So until now at 75 minutes, you've been able to get credit for the 99292, the second hour, and CMS made a change and it's now 105 minutes instead of 75 minutes. So it really extends out the amount of time to get to critical care for the second hour. As far as if you document critical care, so that would potentially give you either critical illness or critical intervention. Or both. And so if you have high risk and high problem with your critical care and it was only 15 minutes, then that presumably would get you to a level 5 because you have both of those things. But if it's, I guess there might be a condition that isn't as obvious that you got both high risk and maybe a critical care patient who goes home might not. I'm trying to think, like an anaphylaxis would definitely do it because you're giving a high-risk medication in addition to a high-risk problem. So I would say probably most of the time, but if we find examples where it doesn't, we can certainly let you know.
And the critical care piece, we're going to be communicating that separately. We didn't want to muddy the waters with the communication of this E&M codes and the rules around that with the critical care piece, which is a little bit separate. But the key takeaways for us, I think, like most of us, if we're documenting critical care, what we're really trying to do is to decide what number to document. And obviously, we never want to document more than what we're actually providing. But the thresholds that count now, starting January 1st, correct me if I'm wrong, Dave, are 30 minutes. If you document beyond 30 minutes, you can qualify for the first hour of critical care. To qualify for the second hour, you need to document at least 105 minutes. So weird numbers, but those are the numbers. So those are the threshold numbers to keep in mind. So if you think that you're providing 105 minutes of critical care for the patient, note that specifically, understand that that's the threshold. If you document 100 minutes, you will only get credit for the first hour. But again, more to come on that.
Fuzzy math.
Yeah. And then Chris Wilde says, are there any thought that patients can read the ED note in certain social determinants of health facts that will upset them as being in an ER note? I think the answer is yes. We've had some discussion behind the scenes about this, and the reality is that we need to call it out. It is part of their presenting, set of issues. We need to be frank and document that, not for many reasons, not the least of which is coding purposes, but also just to be explicit in terms of all the things that contribute to this patient's ability to be diagnosed and cared for. But we need to be thoughtful about how we do that, right? So you wouldn't say this is a homeless crack addict. You might say this patient has no permanent housing and unfortunately suffers from substance abuse or something like that. So just be careful in the wording that you might choose to document those things. But I think there's no harm whatsoever in documenting them explicitly, so long as you confirm that they are true. All right. I think that's it. Thank you, Dave. Excellent presentation. We appreciate your expertise on this and for joining us here today. Very helpful. For the MEP folks, there will be some ongoing communication around this. Please start to think about this. When I worked a shift the other day, I started already trying to implement some of these changes, put them in my note. There's no harm in doing so now, and it will help make that transition easier for me as of January 1st. I would encourage you to do the same. And please make sure that you are reviewing the materials that are sent out and discussing this with your colleagues. We need everyone on board so as to not risk, compromising our ability to code for the excellent care that you guys are providing on a daily basis.